Okay, we can start the presentation.
Okay. ASOCT is my topic, anterior segment OCT. OCT is a non-invasive technique for cross-sectional tissue imaging. It's like equivalent to in vivo optical biopsy. It's a rapid method. It uses near infrared spectral range, which has a penetration depth of several hundred microns in the tissue. It can be, anterior segment OCT can be used for ocular surface, cornea, anterior chamber structures, aqueous outflow systems, and recent advances in anterior segment OCT are for evaluation of anterior segment vessels, iris, and lens. It can be used to assess the tear film in dry eye disease. Also, it can be used intraoperatively for real-time imaging during the anterior segment surgery. It can be used to assess the aqueous outflow with angle assessment in cases of glaucoma. So the importance is pre-operative diagnosis, intraoperative surgical management and planning, also post-operative outcome, monitoring the outcome, assessing the outcome and management of any complications. The principle, as mentioned, is a low coherence interferometry based on Michelson's interferometer. It is the time delay and the intensity of the infrared light, which is reflected from the tissue structures, is compared to a reference beam. The interference beam lead to cross-section of images of formation of the tissue of interest. Multiple A scans are combined to form a 2D B scan. So this is a picture regarding the same. This is a broadband light source from which the beam goes to the beam splitter. It splits the beam into reference mirror, two beams which goes to reference mirror and the sample tissue. The resultant beam is detected from a detector and anterior segment OCT images are got. So there are three types of ASOCTs. One is time domain, in which we measure the time delay of the infrared light reflected from the tissue of interest and from the reference mirror. Here the position of the reference mirror is changed. It's like this. The second one is spectral domain OCT, in which the interference beam is in the form of a spectrometer wave, spectrum we get it and we measure it through a spectrometer. The mirror is fixed in this case and spectrometer detects the spectrum of the varying wavelength of the light. The calculation is through Fourier transformation. It is high axial resolution scan. Examples are spectralis and Cirrus OCT. Then the third one is swept source OCT, in which the source of the light is different. It's a tunable laser source. So similarly, the beam's spectrum is generated and through Fourier transformation, it is measured. There is a difference of the wavelength between spectral domain and swept source. It is more important in cases of 3D imaging. In cases of glaucoma, the examples are Cassia, Entrion, and Optoview, which is of Zeiss. The classification of the three. In time domain, as mentioned, we change the reference mirror position. The broadband light source of 1310 nanometer is used. So it's a longer wavelength, so the tissue penetration is more, but the axial resolution, as we can see in comparison, is less. The speed of image acquisition is also less. It is a slow mode. Then we have two of the Fourier domain OCT, spectral and swept source. In both, the reference mirror is fixed. The light source wavelength is less in spectral, hence the resulting resolution is more. In swept source, the wavelength is increased a little bit, and the resolution is about 10 microns, but the speed is maximum in the image acquisition speed is maximum in case of swept source. From this table, we can see as the wavelength is more, the tissue penetration is more, and the scan depth is more, but the resolution is less. So in all these three, the mid path is acquired by the spectral domain OCT, in which the wavelength is middle and the resolution is the best. So swept source through high wavelength gives deeper and higher tissue resolution, but there is a reduced sensitivity roll-off, which means that even though the tissue depth is increased, the sensitivity of resolution is good. Hence, normally in ASOCT, as we go deeper, the resolution decreases. As the iris comes, the resolution is lost. We also have intraoperative OCTs, which are of two kinds, portable OCT and microscope integrated OCT. Portable OCT can be handheld and microscope mounted. The portable OCT is cost efficient and better in case of pediatric cases. The disadvantages is motion artifact in cases of handheld OCT. Microscope mounted is better with axial stability and foot pedal control. Disadvantages are increased surgical duration and sterility is compromised. Examples of it are spectral biopterin and optoview. Microscope integrated shows us parfocal and coaxial images, and with a real-time surgical view is obtained. So we can see the tissue interaction with the instrument in real time. The problem is it is not compatible with metallic instrumentation, and also there is lack of automated tracking, and real-time image for volumetric analysis is not possible. The examples are Hack Street Surgical OCT and Zeiss Riscan 700. Now, a practical application of ASOCT in our OPD will be in cases of cornea. So the first thing, the most common patients which come to our OPD is meibomian gland diseases. So this is how ASOCT helps in that. Normally, in case of dry eye patients, we do Schirmer's test. The limitations are it's invasive method, so reflex tearing is stimulated. Then the results are variable. It's a subjective test. The reliability is low. In ASOCT, it's a non-contact method. Hence, we can correctly assess the tear meniscus. This is a triangle which we see in ASOCT. So this the tear meniscus height can be seen, and the tear meniscus area and depth can be assessed with almost complete accuracy. And hence we can with the tear meniscus height and area, we can differentiate between healthy and dry eye patients. Then there is assessment of epithelial thickness, which is also seen to be varying in cases of dry eye patients. So tear film dysfunction causes corneal, limbal, and bulbar conjunctival epithelial thickness, and various other diseases which cause induce corneal conjunctivalization, like limbal stem cell disease. So ASOCT helps in evaluation of conjunctivalized corneas. It helps in determining the surgical treatment, reducing the corneal graft rejection chances. Also, it helps to assess the autologous SLET patients with limbal stem cell deficiency. It helps to conduct intraoperative scanning and pachymetry mapping also to guide and assess the removal of delicate fibrovascular pannus, which is seen in these cases. We can see meibomian glands like a cluster of grapes in ASOCT, and hence we can subsequently assess the dropouts and the distortion of the glands, which is seen in meibomian gland diseases. In cases of ocular surface squamous neoplasia, we have to use ultra high resolution OCT. So squamous neoplasia has these classical characteristic features. We can see a hyper-reflective layer, increased epithelial thickness. There is almost abrupt transmission from normal to abnormal epithelium, and we can always see a distinct plane between the lesion and the underlying tissue. In cases of anterior segment tumors, which are larger and pigmented and vascular, UBM is definitely better, but we can also use ASOCT for primary stromal cyst. And now OCT angiography is under studies for vascular tumors like malignant iris melanoma and benign iris lesions. So in assessment of corneal opacities in children. So as we know, children are very uncooperative for slit lamp examination. So if a child comes with a corneal opacity, we can use a handheld OCT and just do a classification of the corneal opacity which the child has. So there are three types of opacities which we can see. One is type 1 Peters anomaly, in which there is iridocorneal adhesions. In type 2, there is posterior lenticulocorneal adhesions. And then there is congenital corneal staphyloma, in which there is anterior bulging of the ectatic cornea and pigmented epithelium cell lining of the posterior corneal surface. So this classification helps in guideline for diagnosis as well as management. So the previous one, the type 1 anomaly, has a better prognosis than the type 2 ones. In cases of refractive surgery management, just a minute. It is of use in refractive surgery management, uh, as we can assess the flap thickness, flap depth can be assessed. Flap interface can be seen, and if post surgery, if there is any flap displacement or if there is any fluid in between the flap and the cornea, we can measure the residual stromal bed following the LASIK surgery. During the surgery, if we have intraoperative OCT, it can be a rescue tool in case of lenticular extraction, in case of SMILE surgery. We can see the site of the retained lenticule, also the difficult place to take the lenticule. If there is any scar or thickness, we can assess that on the intraoperatively on the table. Post laser, it can be used for corneal power evaluation in if we have to implant an IOL. In non-laser refractive surgeries like phakic IOL, it helps in visualization of the IOL, also the vault and the distance from the intraocular lens we can see. In cases of excimer surgical procedures, it can be used as in case of PTK to assess the morphology of the corneal flap created with the femtosecond laser. These are a few images how we will see falling conditions in the ASOCT. In keratoconus, we can use it for epithelial mapping, assess the focal thinning and asymmetry. And also swept source OCT can be used to diagnose subclinical keratoconus. This is how an acute hydrops looks. We can see intrastromal clefts and we can also measure the corneal thickness. Post-treatment also, we will be able to see how the edema has resolved and there is some amount of DM scarring, and how the edema resolves, that we can see. We can see a demarcation line in cases of corneal collagen cross-linking. We can use it in evaluation of cornea post and pre intracorneal ring implantations. It can be used variably in cases of degeneration and dystrophies. It is not diagnostic, but it is just an adjunctive tool for the following. Dystrophies. So this is how a basement membrane dystrophy looks. So we can see hyperreflective deposits which are going into the epithelial layer. These are the basement membrane deposits. This is the anterior strome. So this is a granular dystrophy, how it looks. There is increase in the thickness. There's early stage lattice-like structures, hyperreflective deposits. This is how the image will be there on slit lamp. This is just a correlative it's a tool just to correlate our findings. Here we can see it's an advanced granular corneal dystrophy. Here we can see the scarred areas. This is how a scar will look on anterior segment OCT. This is in the anterior scarring. This is the anterior stromal deposit. These are the deeper deposits. Also, if there is any scarring, we will see a shadow like this, and hence we will not be able to assess the endothelial, what is there in the endothelium, or if there is any other pathology in the endothelium. So this is kind of a disadvantage for the ASOCT. This macular dystrophy image, this is a macular dystrophy in which there is uniformly hyperreflective images. We can see there is no clear area in between. We can see the corneal thinning. It can involve all the layers from the epithelium to the Descemet's membrane. This is how a lattice dystrophy in a advanced stages will look. Then endothelial corneal dystrophy, if it is just plain endothelium, diffuse dystrophy, we can see there are nodular endothelial cells and in the early stages. So as I said earlier, it is just an adjunct, it is not diagnostic. We can just see the type and the extent of the material deposited, which can help us in surgical planning, whether to go ahead with a superior laser or keratoplasty. This is how a pterygium will look on anterior segment OCT. We can see the depth of the pterygium and we can also see the depth of the cornea. This is how a contact lens will look. So this is how pseudophakic bullous keratopathy can be seen. There is increase in the thickness of the cornea we can see, and there are a few bullae can be seen. This is a cornea iridic scar, how it looks. This is the iris. This is a retrocorneal membrane. So if we have a corneal opacity, we cannot see what is there behind. We can go for any procedure for the cornea if we know what is behind, if we expect any bleeding or any adhesions of which we intraoperatively can be seen with the help of ASOCT. So in cases of infective keratitis, it is a clinical diagnosis which we can do with the microbiology and slit lamp examination, but also we can see the infiltrate as a hyperreflective area and retrocorneal pathologies as previously described with the width of the endothelial plaque, and loss of different layers can be seen separately like epithelium stroma, and loss of all corneal layers also can be seen. Fungal herpes and CMV virus keratitis have distinct patterns on the OCT. Fungal has two unique patterns. In localized and diffuse necrotic stromal cystic spaces can be seen. In herpes keratitis, stromal keratitis, there is microcystic edema and keratic precipitates. And in CMV endothelitis, there is protruding structures from the posterior cornea, which can be dendritic, dome shaped, quadrangular, sawtooth shaped. So in keratitis, we can just evaluate the keratitis and treatment response can be seen. This is how infective keratitis looks. There is a epithelial defect, loss of epithelium can be seen, loss of corneal layers can be seen, and increase in the thickness can be seen. Retrocorneal pathologies can be seen, and accordingly the management can be planned, surgical management. In cases of glaucoma, this is the landmark which we see in cases of glaucoma in ASOCT. So the scleral spur helps in further evaluation of the glaucoma patient. There is qualitative and quantitative assessment. In qualitative assessment, we can just see the opposition between the iris and the inner corneoscleral wall. The only limitation is it is subjective. Where we place the marker, from there we will measure the angle. So this is very much dependent on the person who is measuring, if it is accurately placed or not. Also, it does not exactly correlate with the appositional closure as defined by the gonioscopy. And also in certain cases, the scleral spur is not visible, and hence we cannot assess the angle with the ASOCT. Quantitative parameters which are measured in ASOCT are angle opening distance, angle recess area, and trabecular space area. This is how we see it. Iridocorneal apposition is there in this case. This is anterior iris convexity we can see. This is how the anterior lens, the lens is seen. This is the anterior lens vault. So as I mentioned, it can be used for appositional angle closure, but it can be seen only if the cornea is clear and the patient can sit upright. These are the limitations. UBM should be used when cornea is cloudy. And there is a good visualization with ASOCT of intra-bleb structures, glaucoma drainage device placements. Also post-surgically, implications it has. Recent advances in anterior segment imaging are iridocorneal contact index, which can help to assess. It's a software which can help to assess the percentage of angle closure in the eye once the scleral spur is manually identified. So scleral spur is very important to identify before we go ahead with ASOCT. Rest we cannot, otherwise we cannot assess the rest of the things. Definitely clinical examination cannot be replaced. I could not get a 360-degree video. There's a 360-degree video in which we can see the entire angle on ASOCT and hence assess if there is any synechiae, like in these cases, in any of the areas of the angle.
The
So,
images that you are showing, which machine is used for taking
so
these images?
this is Cassia machine, sir. Cassia anterior segment OCT.
Okay. And what is the difference between this and the anti-segment OCT that we use, which is the
So we have in Kolhapur center, we have OptoView, sir. That is a swept source, sir.
that's not swept source, that's a spectral domain OCT. And what is the difference between this and the Cassia or other ASOCT? Any other ASOCT that you know?
So spectralis is the time domain, sir. Sir,
No,
in
no.
our Kolhapur center,
Spectralis is not timed out. Okay.
okay.
What is the anti-segment OCT of Spectralis or Heidelberg?
So,
Which is the spectral domain OCT that we are using, or sorry,
op-
swept source OCT that we are using?
sir, in Kolhapur Center, it is OptoView.
Yeah, OptoView is a spectral domain OCT.
Okay, sir. Sir,
And
actually,
which,
I asked, discussed there, but nobody was knowing clearly, so they told me it's swept
who
source.
told?
Okay, sir.
Optometrist.
Yes, sir. I spoke to. They said it is Care Group, but I said it is OptoView Zeiss machine. That's why it was little confusion regarding that.
No, no, it's a OptoView machine. Anyway, the
Okay, sir.
swept source OCT that we have is ILMaster 700, which uses swept source
Okay, sir.
OCT, but it is not for anti segment as such. Like, no, it's
Yes.
used for anti segment, but it's more for biometry. So
Okay,
it
sir.
uses the corneal measurements for the IL power calculations,
Yes.
particularly the posterior corneal power using the
Yes.
anti-velocity, and it also measures little bit of retinal central part also. So it's a swept source.
Okay, sir. Okay, sir.
Okay, so the devices which are particularly used for anti-segment OCT, what is the wavelength that is used?
So, 800 to 840 nanometer.
No, that's
So,
the wavelength which is used in retina OCTs.
okay, sir.
So
So, the,
OptoView and Optopol and other OCTs or Topcon we have, they are using this 800 to 850
yes.
nanometer light source.
Yes.
Okay, so ILMaster 700 uses around 1050 nanometers.
Okay, sir.
Okay, and the ideal ASOCT, which is for mainly anti-segment imaging, uses a more
13.
infrared. Yeah, that
Yes.
is 1300 nanometers.
Yes.
So 1300 nanometers is used in Anterion, which is of
Yes.
Heidelberg. Okay,
Yes.
Cassia,
Yes.
Optoview and Zeiss. Zeiss earlier had a ASOCT, but nowadays they don't have. It was called Visante, but now they don't have.
Okay,
Okay,
sir. Okay, sir.
and so mainly Anterion and Cassia, these are
Yes.
purely anti-segment OCTs. And the advantage of 1300 nanometers is that it penetrates sclera more.
Penetration. Yes.
So uh, the retina OCT that what we use will not be able to see inside the sclera, but
Okay, sir.
this one will have more penetration.
Okay, sir.
Okay. So if we do the same imaging what you are showing pterygium with
Yes.
the regular OCT that we use for retina, it will not show the posterior corneal surface below the pterygium.
Yes, sir.
Okay.
Yes, sir.
Yeah, go
Advan
ahead.
yes, sir. Advantages of ASOCT over UBM are the resolution is better and it is non-contact. It is most commonly used for appositional angle closure. And as I said, it can be used to clear cornea and the patient has to sit upright. Over gonio is that it is can be performed in dark under physiological mydriasis and it is non-contact. So more patient cooperation is got. The problem with ASOCT is the inferior quadrant. We cannot, the reproducibility is less because of scleral spur cannot is variably placed than nasal and temporal quadrants. And also the limitation, depending on the type of OCT, is that it cannot penetrate beyond the iris, and hence structures posterior to iris cannot be visualized, and the types of glaucoma like plateau iris and phacomorphic angle closure cannot be assessed with the help of ASOCT. About intraoperative OCT, it helps in real-time visualization of intraocular structures during the surgery. Uh, like especially during the corneal surgeries, it is very much valuable. It helps in understanding the intraoperative dynamic and decision making. So in cases of PK, in the beginning of the surgery, we can assess the corneal thickness, the depth and extent of the opacity, the anterior segment anatomy, if there is any peripheral anterior synechiae present beyond the opacity, which we cannot see clinically. During the surgery, the depth of definition, the corneal debulking, layer by layer separation of the adherent glaucoma, there is hydrocorneal adhesion or if there is any iris incarceration at the graft host junction after passing, the sutures can be assessed during the surgery. At the end, we can assess the graft host apposition, the adequacy of the suturing, the depth of the bite, also if there is any retained host Descemet's membrane in the PK in cases of congenital hereditary endothelial dystrophies. There are a few studies to evaluate the importance of ASOCT in lamellar surgeries. There are two studies, Pioneer and Discover. The Pioneer discovers the importance of the portable SD-OCT or microscope-mounted OCT in lamellar surgeries, and Discover measured the importance of microscope-integrated OCT. The results were almost same in both the surgeries, that around 38 to 48% surgery, it helps in guiding the decision making and understanding the intraoperative dynamics. That so,
Yeah, over.
yes, so it's done.
Okay, okay. So any questions from others? Yeah, Kishan, you are there. So what are the ASOCT uses that you have seen so far?
Sir, for anterior layer of the cornea and descent membrane detachment in case of.
Right. What is the Nilambika is there? What is the use of epithelial thickness mapping with ASOCT?
Sir, for last refractive surgery workup,
Yeah, what is the significance? Yes, Namrata. What is the use of epithelial thickness mapping using ASOCT?
Sir, in cases of keratoconus assessment, we can do epithelial mapping if there is any subclinical keratoconus or the depth in cases of trans PRK, sir. We will
Yeah.
get the
Yeah. So in early keratoconus, what are the changes seen in epithelial thickness?
so there will be thinning corresponding.
Yeah, it is said that the epithelial thinning is the first sign of keratoconus. Because what happens is that first the cornea starts becoming thin and starts becoming steeper. But usually the epithelium will try to cover up that area. So the area over that steepened area will become thinner.
Yes.
So that's why it is, and it might be masking the actual topography. Is there any topography which is used to measure the stromal topography? That is, epithelial thickness is removed and only stroma is measured. Do you know any such topography?
Mhm. No, sir.
Yeah, so Dr. Rohit Shetty from Narayan Netralaya, they have devised a software where they measure the epithelial thickness and the OCT, and based on that OCT, removing that anterior epithelium by software, they measure the stromal topography. So
Okay.
that can be used for again early detection of keratoconus changes. Of course, so far the earliest changes of keratoconus are seen on Placido-based topography.
Yes.
Okay. Which Placido-based topography we use?
So Topcon is there.
Not Topcon.
TOMI is there, I think.
TOMI, topography, and any other?
Yes, sir.
In Sangli, which machine we use?
Serious, sir. Serious pentacam.
So Sirius, what is the technology that is used in Sirius?
Sir, both the Placido disc and
Scheimpflug principle is used in that.
Yeah, so it's a Scheimpflug camera or imaging plus Placido.
yes.
Both are used. It is not OCT, it's Scheimpflug. Okay. And
Yes.
what OCT based corneal measurement which machine can do? So all the other OCTs like OptoView OCT and Optopol OCT or Topcon, they also have additional tool to measure the corneal power. So those are additional modules which are there.
Yes, sir.
Okay, so what is the use of ASOCT in case of cataract surgery? Few things Kishan told about post-operative complication to check the incision, descemet detachment, etc., epithelial changes, and anything pre-operatively.
Sir, in tumescent cataract, sir, or Sinike, we can see assess.
We can use it for in posterior polar cataracts to check
Okay.
whether there is breach in the posterior capsule.
Oh,
And also post-refractive surgery patient, we can measure the corneal power because it will measure the posterior corneal power also separately.
yes.
So we can use that. Okay, any other questions? Okay, ठीक है नम्रता. Okay,
Thank you, sir.
yeah, good.